It is officially time to begin our presentation. Really appreciate everybody joining us. Welcome, everyone. Thank you for joining us for this webinar focused on the FREEDOM-1 study in kidney transplantation. This session is 60 minutes with approximately 40 minutes of presentation, followed by 20 minutes of question and answers. We ask that you please refrain from using the chat function during the webinar to avoid distracting messages. Please hold your questions until the presentation is complete and then use the Q&A function. We encourage you to ask questions. At the bottom of your screen, use the Q&A function after the presentation. And please note that closed captioning, live closed captioning is now available by clicking the CC closed caption icon at the bottom of your screen. I'm Lisa Bonebrake. I'm an Alport patient, a parent of a patient, and executive director of Alport Syndrome Foundation. For those of you who are new to us, Alport Syndrome Foundation is the leading independent nonprofit organization in the US, educating and giving a voice to Alport Syndrome community of patients and families. Our mission is to improve the lives of those affected by Alport Syndrome through education, empowerment, advocacy, and directly investing in research. It's very important to us that patients are informed about opportunities to participate in clinical trials. As a patient community, we are motivated to change our family stories, and we understand the critical role of research and clinical studies. Transplant itself is complicated, let alone innovation using stem cells and new technologies. For this reason, we felt it would be best for patients to be informed about this opportunity through a webinar and access to experts who are involved in the process. Alport Syndrome Foundation approached the study sponsor, Tolaris Therapeutics, about the possibility of organizing this webinar to help patients understand the study. We have received no funding or sponsorship from Tolaris for this webinar. Though the FREEDOM-1 trial that will be discussed today is not solely focused on Alport syndrome, it is a study that is open to Alport patients. The study is not a cure or therapy for Alport syndrome. Instead, this study offers hope and much needed innovation in kidney transplantation. Alport patients often progress to end-stage kidney disease and require transplant. I'm pleased today to introduce our speakers, Christy Snyder, Associate Clinical Director and Clinical Liaison for Tolaris Therapeutics, who will provide a bit of context about transplantation for patients who are very new to the process. And Dr. Nancy Krieger, Chief Medical Officer for Tolaris Therapeutics. Dr. Krieger has 15 years of diverse global experience in the pharmaceutical industry. Before joining industry, she was a staff transplant surgeon at Mount Sinai School of Medicine in New York. And Dr. Krieger will be really walking through the study itself. After their presentation, my Alport Syndrome Foundation colleague and fellow Alport patient, Kevin Schnur, will moderate the discussion with the question and answers. Kevin is a 6-year post-transplant patient, having been given the gift of a donor kidney from his best friend. Kevin is our Director of Communications and Patient Engagement. So now I'll hand things over to Dr. Nancy Krieger.
There you go. Can you hear me now? Thanks, Lisa. I'd really like to thank the Alport Syndrome Foundation so much for the opportunity to speak with you today. Let me introduce myself. My name is Nancy Krieger. I'm the Chief Medical Officer of Tolaris Therapeutics. And as a kidney transplant surgeon, I'm just really excited to tell you about our FREEDOM-1 study that is looking at our investigational therapy. It's a cellular product called FCR001 for kidney transplant recipients to enable patients to live free from lifelong medications that are needed to prevent transplant rejection. And this is really what we call the holy grail of organ transplantation, which enables kidney transplant patients to be completely free from immunosuppression. So now I will turn it over to Christy Schneider.
Hello, and thank you for having me. As Nancy and Lisa said, my name is Christy Schneider, and My background is as a solid organ kidney transplant coordinator and nurse practitioner. So I'm really excited to be here and to tell you a little bit about our trial with Nancy. And I just want to start out by just kind of reviewing some of the conditions that may cause kidney disease, and why we may why patients may require transplants. There are a number of reasons for kidney disease, and what I have listed are just a few. But we kind of put them in buckets of inherited or genetic conditions, including Alports, things like polycystic kidney disease. There's autoimmune conditions that can cause it, one called FSGS, or focal segmental glomerulosclerosis. It's kind of a mouthful. Another one called IgA nephropathy is pretty common in lupus. In addition, we will sometimes see kidney disease in individuals that have type 2 diabetes and chronic high blood pressure. The couple treatments for end-stage renal disease, really at this point there are only two, and they include dialysis and kidney transplantation. Dialysis includes having a machine filter waste products and extra fluid out of your blood the way a normal kidney would. The issue, though, the concern is that dialysis only filters the blood during the treatment session, not the entire time. And it only really does about 10 to 15% of what a normal healthy kidney would do. Many patients actually undergo dialysis while they are awaiting a kidney transplant. With kidney transplantation, that again is a second option for an end-stage kidney disease. And with that, there's two different ways to receive a kidney. One is called living donor kidney transplantation. And with that is when either a family member or a friend may donate a kidney. That's called direct donation. That's the most common with a living donor kidney transplant, where a recipient will know their donor. Another option for living kidney donor transplantation is called paired donation. This is where a kidney donor or recipient may want to donate, however, they're not matched together. So they're paired with another pair that then they can make a match for two kidney pairs. There's another way of donating through living kidney donor transplant called non-directed donation. And this happens when somebody is what's called an altruistic donor. So they want to just give a kidney to call it the national pool, really to kind of just to help others and be very selfless. And then the other option for kidney transplant, in addition to the living donor kidney transplant, is what we call a deceased donor kidney transplant. And that is also very, very common. And that is receiving a kidney from someone who has recently passed away. So I just wanted to talk to you a little bit about the kidney transplant and donation process. As I said, I am a kidney transplant coordinator by background. So just want to tell you a little bit about what may be expected if you were ever in the situation in which you may need a transplant. The transplant team is a large group that really looks at all aspects of both kidney donors and kidney recipients. And it's made up of transplant surgeons, such as Dr. Krieger, transplant nephrologists, which are kidney doctors, nurse transplant coordinators, and they are really the ones that will see the patients through the whole process from when they first contact a transplant center, usually through the rest of their life after they've received a transplant. Pharmacists, there's dedicated transplant pharmacists that have specialties in this area. We always have people see social workers and psychologists just to evaluate what's your home and family situation. Do you need any extra help that we can give? Additionally, we always have a dietitian on the team. And this is because there's certain requirements that you may have if you have kidney disease, and those may change after transplant. In addition, patients are always provided with a financial counselor because transplant can be expensive and there's different options for insurances and Medicare. So they work through that with you as well. And if you're a kidney donor, if you're a living kidney donor, there's always what's called an independent living donor advocate. And that is somebody that's assigned to a kidney donor to make sure that their needs are really being represented. And this is really something that they want to do, that they're not getting any outside pressure. So that's really, really important. Some of the example of medical tests that you may receive if you're either going to receive a kidney transplant or you're going to donate a kidney, they're very similar. We do blood tests for what's called blood type compatibility. So if you're the same blood type or compatible blood type. We do what's called tissue typing, and that really is to determine if you are a match. If your cell types, your tissue typing matches somebody else. We do blood tests for transmissible diseases. Look at your heart and lungs through a chest X-ray or electrocardiogram, and we also do cancer screening. So this is not an inclusive list. This is some of the more common tests that you may undergo or be asked to provide if you ever find yourself in the situation of having a transplant. So with that, I will, and some of the benefits of kidney transplant, as comparison to dialysis, there is a longer life expectancy following a transplant as compared to dialysis, and studies have shown that there certainly is a better quality of life as compared to dialysis. Dialysis, I said, it does a pretty good job of clearing the toxins, but there is a schedule. Individuals often can be on a dialysis machine for 3 to 4 times a day, 3 times a week. With kidney transplant, there's less dietary restrictions because you don't have the kidney disease that your new kidneys filtering out those toxins. People who have had a transplant have fewer blood pressure medications, and there's also overall lower treatment costs. So with that, I'd like to turn it over to Nancy to tell you a little bit more about kidney transplant and what the FREEDOM-1 study is about. Thank you. Nancy?
Thank you. So as Christy was saying, kidney transplantation clearly saves lives, but requires taking anti-rejection medications for life, which have their own challenges. For one thing, chronic use of these medications has side effects. So first of all, some of these medications can even be toxic to your kidneys. So the average life of a kidney transplant is between 12 and 20 years. And a third of living donor and a half of deceased donor kidney transplants actually fail within 10 years. Immunosuppression can also cause your blood pressure to go high. It could induce diabetes and cause high lipids and cholesterol levels, as well as weight gain. And really, cardiovascular disease is a leading cause of post-transplant mortality. Immunosuppression also can increase the risk of infections in certain cancers. And as shown in that picture on the right side, there's also a very high pill burden with decreased quality of life, which could result into compliance issues too. So people tend not to want to take medications like this for the rest of their life, which could actually affect the outcome. So on the next slide, what is FCR001 cell therapy? It's an investigational cell therapy containing living stem cells from the kidney donor and is infused as a stem cell transplant into the kidney as a single dose. The stem cells then take up residence in the recipient's bone marrow and generate new immune cells. So really the goal is to create a dual immune system where part donor and part recipient immune cells coexist. So essentially, the recipient's immune system is tricked into seeing the donated kidney, the transplanted kidney organ as self. So the existence of this dual immune system, both of donor and recipient, is referred to as achieving chimerism and potentially enables long-term immune tolerance of the kidney transplant. So with this therapy, immunosuppression can potentially be stopped, which could allow the recipient to live free from taking daily medications and the many complications associated with chronic treatment with anti-rejection medications. So here are the results from a phase 2 clinical trial that we previously conducted from 2009 to 2016 in 37 living donor kidney transplant patients that were treated with our product FCR001. So 23 out of 37, or 70% of patients were able to be discontinued from their immunosuppressive medications by 1 year after their transplant. And 100% of these patients have been able to been taken off their anti-rejection medications, have remained off immunosuppression without having rejections. And this has been durable from 3 to 11 years post taking off of immunosuppression, with a median time of greater than 5 years. 7 of these 7 patients that had prior autoimmune diseases of their kidneys, such as IgA nephropathy or FSGS that Christy previously mentioned, have had no recurrence of their disease. And importantly, the safety profile reported in this study was as expected for a kidney and stem cell transplant population. So what is the FREEDOM-1 study? It is a clinical research trial evaluating FCR001 to assess the safety, efficacy, and overall benefit of FCR therapy to prevent rejection of a transplanted kidney without the need for lifelong anti-rejection medications compared to standard treatment. This study is supported by the positive results from the phase 2 trial I just mentioned to you. What does participating in FREEDOM-1 entail? Well, qualifying recipients and their living donors will be randomly assigned as a pair to receive either FCR, cell therapy, or to the control group receiving standard anti-rejection treatment. Twice as many of recipients will be assigned to receive FCR compared to standard treatment. And I do want to point out that Teleris will reimburse all study costs, travel, accommodation, and immunosuppression for up to 5 years, the duration of the study. You may qualify for participating in FREEDOM-1 if you are at least 18 years old, your donor has recommended that you should have a kidney transplant. This would be your first kidney transplant. A suitable living donor between ages 18 to 60 has been identified. The living donor is willing to undergo standard mobilization apheresis procedures to collect his or her stem cells, and that you haven't been diagnosed with or treated for any type of cancer. So this slide gives a detail. It's a cartoon that gives a detail of the actual study participation. So approximately 3 weeks prior to the transplant, the stem cells are collected from the kidney donor. The stem cells are then sent to our manufacturing facility to prepare the product. And here we remove cells that are undesirable and enrich the product for stem cells and facilitating cells that help the transplant and graft. 4 days prior to the transplant, the recipient comes in and undergoes 3 days of outpatient conditioning to make space in the bone marrow for the donor cells to engraft. On day 0, the recipient then undergoes his or her kidney transplant procedure. The day after the kidney transplant is when the FCR product is infused. So during the next 6 months, the patient will remain on standard immunosuppression to maintain the stem cells in the transplanted kidney and returns to the clinic at regular intervals for routine monitoring. For months 6 to 9, if there's evidence that the donor stem cells have taken, in other words, there's donor chimerism present, and the kidney function is totally stable with no rejection, the patient's otherwise doing well, then the anti-rejection medications are gradually weaned. And then at 1 year, if everything else remains stable, the recipient will become free from all chronic immunosuppression. Thank you very much for your time and listening to this and your interest. This slide shows you some ways that you could connect online to our study or send emails to us. I think at this point in time, I think we'll entertain any questions that you may have. And if for some reason we run out of time, Christy and I will do the best to answer your questions in a timely fashion. Thank you.
Thank you, Nancy. Thank you, Christy. We do have quite a few questions coming in the chat. The Q&A, I'm sorry. Please don't use the chat. You guys have been great at keeping that just for technical issues. Again, if you have questions, use the Q&A box located at the bottom of your screen. I will see those questions and I will pass those along to our experts here today. I do have a few questions that came in offline as well. So while our attendees are queuing up and adding their questions to the Q&A box, I'll get to some of these questions that we've already previously received. One question came in regarding Telaris covering 5 years of immunosuppressive coverage. And I think one thing that's important for our community to realize is, would you mind talking a little bit about the costs of immunosuppressant coverage, especially for those maybe not familiar with the transplant process? The transplant drugs are normally necessary for the life of the patient and how that can be a financial burden for some patients. Maybe Christy, maybe that might be best for you.
Sure, I'd be happy to answer that. With immunosuppressant medications, as Kevin said, they are very, very expensive. Medicare currently only covers up to 2 to 3 years after the transplant to cover the anti-rejection medications. And after that, it really is up to the patients and the patient's recipients, the patient's insurance to cover them. They are a lot, and even with insurance, there can be pretty high copays. So we wanted to ensure anyone enrolled in the study wouldn't have that barrier, like I said, for the 5 years, because we do know that they're quite expensive.
Excellent. Again, thank you for just making note of that for all those in our community who might not be aware of the very high costs associated with immunosuppressive drugs. Next question here comes from Sharon in our chat. She'd like to know, if you go through this process, does it make it more difficult if for some reason there were to be a second transplant needed? Which goes back actually to another question I have. So I want to make this a two-parter here. You mentioned the word chimerism, which is probably a phrase that's new to not only myself and my colleagues, but probably many of the folks listening to today's webinar. Is there a chance of rejection? That's a term that many folks in our community are used to when we discuss a living donor transplant or a cadaver transplant. Is there a chance of quote unquote rejection when it comes to chimerism? That is to say, is there a chance where the chimerism is not properly achieved and the process can be reversed or rejects? If either one of you would like to touch on that topic.
Sure, I could do that. So chimerism, again, is a coexistence of two immune systems living together. And in our experience, in the 27 patients or 26 patients that were off immunosuppression, so remember that there were 37 patients in the trial, 26 of them, so it's about 70% of patients, were able to achieve durable chimerism, or the two dual immune systems living together for 6 months. And we decided, just from our experience, that when someone has the chimerism up to 6 months, it tends to be permanent. To date, every single patient who had chimerism at 6 months has been able to be weaned off immunosuppression without any acute rejection happening. And this has been up to, some patients are up to 10 years, so it's somewhere between 3 and 10-year duration. So it is durable. So these people who have established chimerism do not tend, at least in our study, have not shown to have any acute rejection episodes. So then the question happens, what about those other patients, the 10 patients or whatnot, that did not get weaned off immunosuppression? They basically lose their donor cells for the most part and just act like a regular standard of care transplant patient. So they could have acute rejection, but they will require immunosuppression. In our phase 2 trial, the immunosuppression that those patients, we call transient chimerism, some of them may have it and then it disappears. Those patients tended to be on a little bit lower immunosuppression than standard of care, but this is why we do a phase 3 trial, and we're going to confirm those results. But so those patients that are not have not had the chimerism or the dual immune system persistent could have an acute rejection episode just like standard of care.
So
I hope that answers that question.
Sure. So basically, to sum up one part of the question, as far as if the person does not achieve, let's call it optimal chimerism, that does not work, and they do happen to have acute rejection, they would be in the same boat as any other post-transplant patient who finds themselves in acute rejection. They would just need to pursue a secondary transplant. There'd be really no other difference at that point between them and another patient in rejection. Is that correct?
That is what appears to be the case. That's what we were thinking, that's the case when we haven't seen anything. Since they don't have the tolerance that they could experience the acute rejection.
Excellent. Thank you, Nancy. Next question. How many people overall is Talaris looking to enroll in this trial?
So in the phase 3 trial, I had mentioned earlier, it's a 2-to-1 randomization. So there are a total of 120 patients. 80 patients will receive the FCR cell therapy, 40 standard of care, and that's a control.
Great. Next question from our chat here. Are there any Alport syndrome patients currently enrolled in the trial?
In the current trial, the phase 3, no. In the phase 2 trial, I believe there were 2 patients that had outports. So 2 out of the 37 patients.
Excellent. Next question. You mentioned that this trial is mostly for those 18 and up. Is there any chance whatsoever in the future that maybe if results go well, this may open to those under the age of 18? As this patient noted, they have young children with Alport syndrome, and we do have many in our community that do experience loss of kidney function at an earlier age. Do you foresee any chance where this trial may potentially help those pediatric patients?
That's a great question. Actually, yes, and we're actually required to do that. So typically, you'll do it in adults first in the new therapy, and when you show that it works and we see that it's safe, then you go into the pediatric population. So most definitely. And the time frame probably won't be for a few years, but definitely.
Thank you, Nancy. Next question. As the donor who has to give their stem cell to the living donor transplant recipient, can you talk a little bit about what, if any, risks medically are involved for the donor who has to undergo that stem cell donation process, and maybe explain a little bit to our community what exactly the stem cell extraction entails for that donor?
Sure. So the donor will receive some shots of a growth. It's a product that kicks the bone marrow. It's a drug that kicks the bone marrow, the stem cells out of the bone marrow into the bloodstream about 5 days prior to obtaining the stem cells. And the side effects of those cells might make you, the side effects of those medications might make you have a little bit of bone pain, maybe a little bit of malaise, and somewhat fatigue, maybe a little bit of muscle pain. And to date, there have been no serious adverse events in any of the donors we've seen today, but that's really mainly the side effects you're going to get from that. And then after you have the 5 days of this, we call it growth stimulating factor that helps, again, get the stem cells out of the bone marrow. Then you'll have a line placed inside of you that is hooked up to a machine. Probably takes around 3 to 5 hours or so. And this machine will collect the stem cells. Then, the line's taken out of you, and then the donor, for at least the stem cell part, that part is over for the donor. So it's a little bit, it's five days of medication to kick the stem cells out of the bone marrow, and then they're hooked up to the machine, sort of like a dialysis machine, not quite though, for a few hours.
So thank you, Nancy. Our next question concerns to potential disqualifications from someone who would be a transplantee. This person, Chris, noted, I've had squamous cell carcinoma. Would that disqualify me from this trial?
I'd have to find out more information on your cancer, but most cancers are, unless it's like basal cell or that sort of very, very superficial skin cell, all except for those will likely be disqualified. but I would still go to your physician and have them look at all the records and that sort of thing, to make the final decision.
Our next question came from the Q&A as well. If you could kindly explain the difference between a stem cell transplant versus a bone marrow transplant.
So it's very similar. A bone marrow transplant is really getting the bone marrow directly within your bone. So I don't know if you've ever heard what the iliac crest is. It's your hip, and someone will take a needle and directly take out bone marrow. So it'll have mature cells, it'll have stem cells. A stem cell transplant is really something that's going to be mostly coming from your peripheral blood or cord blood are purely stem cells that are transplanted into you.
Brian in our Q&A feature asks, excuse me, are the treatments provided at my local hospital, or do I need to travel to a specific location for pre and post-op procedures and care?
Very good question. We are developing centers of excellence, so there'll be approximately 15, maybe a little bit more sites spread geographically throughout the country. And you will be required to, because it's really a specialized treatment that you need the kidney transplant and the stem cell transplant physicians together. So you'd be required to travel there. Teleris again will help, it's a financial burden. So we're going to help you with the traveling and reimbursement and when you have to stay in hotels and whatnot. But it depends where you live on the distance between wherever you live and the actual sites. If you go to our website, as our sites get activated, there's an app there that you could see from, you could put your address in and it'll show you the closest site to where you live.
Fantastic. Our next question came from the Q&A from Carol, and she has a question about, I guess, at what point the donor and potential transplantee kind of hop on board for the clinical trial. So her question was, does the transplant process start locally and then the donor and recipient enter the study, or does the workup for the transplant process, that is to say compatibility and things of that nature between a potential living donor and the transplantee, is that kind of enveloped in your study?
So it depends. If you happen to be near a site that, that's close to your house, you probably will have both the local and the study workup at the same time. But typically you'll need to be on the transplant list, let's say locally, and you'll have your workup and you'll hear about the study, you'll select a site, and then you notify the coordinator there that you're interested in the study, and they'll probably ask for your medical records that you'll send to them. And then the center site might want to, look at your, do their own evaluations, which probably is not going to be take as long as at your local, because when you're doing it at your local center, it's it's the first time. So I don't know if that answers your questions. If you wanted more information on that, but you would have to be a transplant, worked up as a transplant recipient.
Hey, Nancy, I can add a little bit more based on my experience as a coordinator. Traditionally, not just for the study, but for transplant in general, traditionally, patients have needed to travel to a transplant center. So if they're not close to a transplant center, they would have to go there and have all of their workup. As I said, there are a number of medical tests that are required. More and more, and particularly in this COVID environment, transplant centers are allowing patients to have those medical tests run locally. And then perhaps they only need to travel to a transplant center, for their one-time evaluation. Similar to that, we have been working on, as Nancy said, a travel program, and specifically we've been working with home health. So more of those tests, even for workup for the study, can be done by a home health nurse wherever you live. We've been working on that because, like I said, with the COVID environment, transplant centers and really all healthcare has really changed, how they've conducted and evaluations and care. So we have tried to incorporate that as much as we can safely into the study as well.
Thank you for that, Chrissy. Our next question comes from Thomas in the Q&A. Is there a possibility that this treatment will be available for a second or potentially even later transplant?
So right now in the phase 3 trial, it's for a first-time transplant recipient. I would foresee in the future that we might be able to go for a second transplant. There, in the phase 2 study, there were 2 patients who actually had a transplant as a child, and then it was their second transplant. But as going into registrational trial, we made it a little bit more conservative. So I would, not for the trial, but I would foresee after that, in certain instances, it could be available.
Fantastic. Nancy, we had a question in the Q&A from Shabir. He wants to know if it would be possible to discuss how the 2 Alport patients did specifically, or if that's maybe something you can publicly release in the future, if that's allowed.
Perhaps in the future. I don't have that information right now.
Great. Are there any additional features when it comes to matching the living donor to the transplant? We know nowadays with the advances of immunosuppression, some patients who are not even a great match are still allowed to be a donor pair due to the medication that's currently available. With your study, do you need patients that are an excellent match or a near perfect match? Could you discuss a little bit about maybe the match level between the donor and the potential recipient and how that may or may not affect your clinical trial?
It does not affect our clinical trial. We've shown that the results from, in kidney transplants, it's 0 out of 6 mismatches. There are a total of potential 6. So there's really no required matching. You could have completely matched versus not matched. So you can't be living related identical. That's, like from a sibling, but out of the antigens matches, you could have anywhere from 0 mismatch to a fully mismatched, and it really shouldn't affect the results. So it's basically just like you do a regular transplant locally. So there's no extra restrictions with just the HLA matching.
Thank you for clarifying that, Nancy. We talked a little bit in the slides before about the workup that goes into matching a living donor and a transplant and the number of tests specifically that the living donor has to go through just to make sure that they're a good match and they're certainly a safe match. As far as post-treatment, what type of tests can folks expect who have been enrolled in this trial to monitor and make sure that they're staying healthy and that the FCR001 drug is working well? Do these folks have to undergo, let's say, a stress test at some point in the future, or are they getting pulmonary tests? What type of evaluations are occurring after the living donor has received the kidney and is currently in this clinical trial?
So pretty much the same types of routine testing that you would see in standard of care. And on top of that, because you're getting your stem cell transplant, you'll probably have, not probably, you will have more frequent testing of your blood counts early on. And one is, you look at your renal function and that sort of thing. But one specific thing to our study is every month you look at the chimerism. So you're able to look at the donor chimerism by looking at, it's a simple test, it's just a blood test to tell you the percentages of donor cells. So you'll be doing that monthly. That's an additional aspect. And I would say looking at your white counts and your cell numbers, neutrophil counts, you're probably looking at that a little bit more frequently the first few months with respect to labs.
Great. Next question from the Q&A. Is a basket study for repeat transplant patients potentially possible?
I mean, right now we don't have that plan. We're trying to get this approved, but once the product is approved, or after, it's probably going to take a few years for that, then we'll be considering adding different studies and adding different populations. But at this point in time, a basket study is not planned.
This next question is going to be for Christy. Came from someone named Kristen in the chat. Will Telarus be assisting at all with identifying altruistic donors?
We have not been involved in that process, and as a sponsor, we need to be independent of that process. So really, it's up the transplant centers do a very good job of working with potential recipients to find ways that they can find a living donor, because ultimately a living kidney donor has the best outcomes, and the deceased donor transplants do very well as well, but a living donor transplant does a little bit better. And so the transplant centers are really good at helping people talk to maybe their family members, their friends, people, and kind of get the word out there's many ways of finding a donor. People are finding them online now. And there's a number of different organizations you can go to kind of facilitate that as well.
Excellent. Next question I'll pass to you as well, Christy. We've talked a little bit before about the positive advantages of a living donor transplant, particularly when they come to quality of life. Would you mind expanding a little bit more about quality of life improvement with a transplant? And if you were someone on dialysis right now who may be content on dialysis, could you explain why a living donor transplant would be a great opportunity? And not only that, but to particularly enroll in this clinical trial?
Sure. And some people, do very well on dialysis and feel well. That usually lasts for some time, depending how well the dialysis is doing about clearing the kind of the waste products. So some people will do better than others. People who have diabetes don't do as well on dialysis as a living donor kidney transplant. Really what we've seen in my experience is, and Nancy can attest to this, after transplant, patients will often say, wow, I feel so much better. I didn't know how, maybe I didn't feel well before, because they sort of get used to being on dialysis and how they feel. They have a lot more energy. They eat more because they feel better, as well as they don't have the restrictions on their food intake. They stay hydrated versus they've had years of needing to just not drink a lot. Also, there's two different kinds of dialysis. One's called peritoneal, where some fluid is infused into the kind of the abdominal cavity that kind of is a way of filtering waste, and also the blood dialysis machine. The blood dialysis machine, people will be hooked up to that for 3 or 4 hours. Some people can tolerate it, but the schedules alone, it can be very difficult for people to travel. When you have that schedule, they might have to, if they are traveling out of state, they need to find another dialysis center that's willing to do dialysis, that they're on the same schedule. It really can be very, very difficult and kind of tied to that. And in general, like I said, just the fatigue that sometimes go around with dialysis, and there's anemias, there's just different things that you just are going to feel, and generally, you're going to feel better after transplant. Like I said, that said, there are people that do feel pretty well on dialysis, but overall, people feel, just have a better quality of life after transplant.
Thanks for that, Christy. I'm post-living donor transplant myself, and I think one thing for me personally was because I was so sick for so long and not realizing that I was sick with Alport syndrome, my quality of life was what my brain told me it was. And once I did receive a living donor transplant, I realized that the quality of life was really much, much higher. But unfortunately, for those maybe that are on dialysis or are feeling the effects of declining renal function or of Alport syndrome or otherwise, or another renal disease, you oftentimes don't realize how sick you are until you start to feel better. So that's important to know. So thank you for discussing that, Christy.
Yeah, we've heard that a lot.
My next question is from the Q&A as well. If you happen to do need another transplant later on in life, would your CPRA be extremely high as you have another stem cells? If either of you could address what CPRA is, and if it would indeed be high if the clinical trial does not work out for the patient.
Sure. So that's really panel reactive antibody or antigens. And really what that is, let's just say you have a 100 or 96 well plates, and you're looking at 100 different types of the most common antigens that you're seeing for transplant. If you drop a blood or of the serum from a patient into each of those wells, the number of cells that light up and have a response gives you a PRA. So if you look at 100 samples and you have 100% light up, that means you have a high, sorry about my dog, you have a high panel reactive antibody, which means you have a higher response to antigens in general. If you only have 1 out of the 100, it's a 1% PRA, and there's a very low reactivity of the most common antigens. So the lower the PRA, the better. So it's a very good question. So if you have a stem cell transplant, do you automatically have a higher PRA or have donor-specific antigens and that sort of things? And what we've seen so far to date, no, we haven't seen that. So it doesn't appear that we're doing a phase 3 trial on a larger number, but we haven't seen that. And early on in our study, we actually, before we figured out the right dose and the right cell dose and a couple of the procedures that we needed to do, we had 2 patients who required a second transplant, and both of those 2 patients who had graft loss actually had a successful transplant. So we do have proof that after this therapy, if, our hope is that it's one kidney for life, but if that happens, it doesn't seem like it would be affected.
Thank you for answering that, Nancy. We had a question going back to the chimerism, and we know from your slide earlier that 70% of people did well. And we're going to discuss a little bit about the 30%. For those 30% where optimal chimerism wasn't achieved, is there a chance that the chimerism can still be achieved in those patients, or is it simply the case that those patients are not able to achieve that optimal chimerism?
So in those 10 patients who either 2 of them never developed chimerism, but in those 8 patients that developed what we call transient chimerism, the first maybe 1, 2, 3 months, there was some level of chimerism, but it gradually decreased. So essentially all the donor cells have disappeared. So there's really not a way of establishing donor chimerism in those patients. I think the donor cells or have disappeared. And at this point in time, we haven't had a procedure where we would actually do another stem cell transplant. So from the initial product, if they go away, there's not a chance of establishing chimerism.
Next question. We have a note here from Kristen in the Q&A. New post-transplant regimens are saving lives and improving quality of life. However, the demand for coordination of care remains a burden for many patients. How does Telarus plan to extend education to healthcare providers who may have limited knowledge and experience for caring for those with chimerism and transplant?
We're going to have educational programs. So again, the critical time points are going to be, the first year, maybe the first 2 years after the transplant. Is pretty much the first year when you're trying to see if you're going to become chimeric and off immunosuppression. And then when you completely get off immunosuppression at month 12, then, the surgeon and the physicians will want to follow you. So the critical time point, these patients will be studied for by the centers of excellence. So they'll really be taking care of that. But there will be educational webinars and just education with the local physicians that you're going to provide them with a little bit more knowledge. We'll have publications and whatnot. So, there's time to prepare. Right now, we're just starting our study, and we're actually working with advocacy groups like the Alport syndrome to really try to educate everyone so they get a good understanding of this program and how to manage these patients and such. But typically, if you unfortunately do not, 30% that do not develop chimerism, you're really going to be managed fairly much like a standard of care kidney and maybe stem cell patient. So it shouldn't be anything unique. And then if you're off immunosuppression, you'll just be followed typically yearly if you're doing well, making sure everything's okay, typical, because you're not going to be on immunosuppression, so you're not going to have to be managed on that. And typically these patients that we've seen, the ones that are 5, 6, 7, 8 years out, 10 years out, they tend to be on less medications, less antihypertensive medications and that sort of thing, what we've seen from the phase 2 data.
Excellent.
And if I could just add on that as well, for those who are not enrolled in a clinical trial, some patients when receive a kidney transplant or a bone marrow transplant, some will be seen at the transplant center for a certain duration of time, number of years, and then they transfer back to their local areas. In my experience, the local physicians are usually still in contact and have a good relationship with the centers where they were transplanted. So realistically, similar to the study, the people that are doing the transplant and the transplant kidney doctors, the kidney nephrologists, they will be talking to your local providers as well. So they will have a number of years where they're going to be really working together. And even though we will be seeing the patients at the centers of excellence will be following them directly, I would suspect long-term that they will be working pretty closely with your own local physicians.
Thanks, Christy, for bringing that up, because that's what we saw in phase 2, that the PI, the investigator of the study, had a very close relationship with the local nephrologist because, time after transplant, they go back home, and if they have little issues or, just a regular, your day-to-day care was managed by your local doctors, your initial doctors, and there's close communication, as Christy mentioned. That's important to know.
Our next question came from Chris, and this is just a clarification of some of the phrasing that was used in a prior slide. Chris asks, what is moderate output conditioning? Is that plasmapheresis?
Oh, no, that's outpatient, moderate outpatient conditioning. So to make space for the bone marrow, the recipients come in to get a procedure. So it's medications. So it's an injection, infusion of medications. And then there's one dose the day prior to the transplant of total body irradiation. It's a very low dose. It's quite low. So you don't have as many side effects as you hear radiation. It's just one dose. And those things together, I believe there's 2 drugs, and I believe you have 3 doses of one drug, 2 doses of another drug, and then you have the very low dose of total body irradiation, and that's what the conditioning is. And it's our product protocols modified after something that was done, a procedure that's done at Johns Hopkins, where they've looked at 1,000 patients or so, both with non-malignant diseases as well as malignancy diseases. And at that institute, it's typically done as an outpatient.
Next question from Kristen in our Q&A. From your phase 2 results, what type of complications between patient and graft survival did you see? Did any of the clinical trial participants have any additional comorbidities, conditions before and after the trial?
So after a transplant, I mentioned to you early on there were 2 cases of graft loss, and some patients had infections. So whether it's due to our treatment, after a transplant, when you're immunocompromised, you'll have infections. So that's pretty a common thing to have after transplant. This is a stem cell transplant. So there were 2 cases of graft versus host disease. I think that was one of the questions I saw in the QA as well. And and those 2 patients that had graft versus host disease ended up being a female, unrelated to male recipient. And that's more common to have graft versus host disease. So we have since eliminated that combination moving forward, just to be conservative. We've done a lot of studies in mice that have really showed that these facilitating cells that I mentioned, so it's a specific type of cell that's proprietary that we've isolated, lowers the incidence and prevents that for graft versus host disease. I know it's a complicated topic. That's why I'm kind of going into a little bit more. But those are the main side effects and such that we've seen. I mean, the patients are on immunosuppression for the first year, and most of the infections and that sort of thing that we've seen in the trial was during that first year. And then later on period, we really didn't see as many of these complications that you typically see when patients are on immunosuppression.
Excellent. My next question is from Thomas in the Q&A. Is this therapy potentially available for liver and or lung transplant recipients, or is it only now in the kidney space?
Very good question. Right now, it's just in the kidney transplant space. We plan on going on to other organs at later date, as well as deceased donor organs, but that's down the line. Right now, it's just living-related donor kidneys.
Thank you for that. Kent asks about long-term immunosuppressive medications and them being nephrotoxic. Christy or Nancy, would you mind explaining what nephrotoxic means and maybe some of the negative side effects of a standard immunosuppressant regime?
Sure. Nephrotoxic means it's toxic to the kidney. So there's a drug called cyclosporin and one called tacrolimus, and they have known effects where they damage the kidneys slowly. Some patients don't see it for quite some time, but virtually all kidneys will have some damage, and it's a varying degree from patient to patient. But if someone gets a biopsy, 5 years or 10 years after the transplant, 5 years, even 3 years, even 2 years sometimes, they'll see it's a specific thing that you could see on the kidney when they look at underneath the microscope, but it's sort of like a fibrous thing. It's scarring, let's just say. So that happens in virtually all patients to different extents. Some of these medications give you neurotoxicity. So like the tacrolimus will give you tremors, or sometimes it affects your memory. You have, memory or what we call CNS toxicity, but tremors, increased blood pressure, your lipid profiles, cholesterol and triglyceride. It could cause diabetes because, like the tacrolimus attacking the kidney, it also attacks the pancreas cells, the beta cells that produce insulin. So you could develop diabetes. Steroids, I think most people know steroids. They could cause hyper blood pressure and the side effects of steroids, cataracts and that sort of thing. What else? Some of them it could cause GI side effects, a little bit of GI discomfort, upset stomach. The MMF, the mycophenolate, isn't the drug that has that side effect. Christy, pipe in if I'm missing something. Is sleep disturbances.
Right, and I was just going to add that the tacrolimus does require monitoring frequently to make sure that you're in a correct range. So in the short term, some of these can be dependent on what the dose is, but long term, as Nancy said, they can kind of cause high blood pressure, diabetes, similar to other long-term conditions we see. But certainly you have to be monitoring pretty closely to make sure that the levels are where they should be to help minimize some of those. But inevitably, they are, you're going to see them long-term.
And then there's the infections just from being immunocompromised, infections, viral infections, bacterial infections, as well as very long down the line, malignancies and increase in certain types of malignancies.
Okay.
Cancers.
Thank you so much, Nancy and Christy. Just want to keep an eye on the time. We have about 3 minutes left in today's webinar. I wanted to thank you both. We went through about 25 questions there. So as you can see, the kidney community is very eager about the study, has lots of great questions. If there are any additional questions that come in after today's webinar, you can certainly reach out to the Chimerism team at the information you see on your screen, or email info@outportsyndrome.org. That's info@outportsyndrome.org. And we'll certainly do our best to get those off to the Chimerism team and get a written response to you. As everyone can see, we are recording today's webinar. Lisa and I will be releasing details about accessing the recording shortly. Again, with 1 minute left, 2 minutes left, Nancy, Christy, if you'd like to have any last minute comments for our community before we log off for today.
Again, it was a pleasure for us to speak with you. I really would like to give you a big thank you for allowing us to speak. And, both of us, Christy and I are both transplanters. She's a coordinator, I'm a transplant surgeon. So this is close and dear to our hearts. And again, it was a pleasure to be able to speak to everyone. And please, if you have questions, please feel free to send them either on what you see on the screen or send it through emails, and we'd be happy to get back to you.
Well, again, thank you both so much. We appreciate all your efforts to improve the life of not only Alport patients, but kidney transplant patients in general. Thank you again so much for your time, and we look forward to chatting you again sometime soon.
Our pleasure. Thanks so much.
Thank you. It's a pleasure.
On behalf of Lisa and Alport Center Foundation, thank you everyone for tuning in.